Since you got gone, ever since you got gone.
Wouldn't paint me as a heartbreaker, but I've said a few goodbyes. I'd make a promise, but I know later I'm bound to change my mind. Depending on the weather I'm going, and hell, baby, nobody knows when. Yeah, if it was a different time, might have been different in a different life. Maybe that plane would never take off. Maybe that bus wouldn't fly the drop. Maybe that tumbleweed in me wouldn't leave every other sunrise. Maybe I'd settle down digging some roots. Find me a farmhouse, find me you. Maybe I wouldn't be already gone again if it weren't for the wind. Wouldn't stay wondering what's out there. I wouldn't saddle up on the breeze. I wouldn't disappear out of thin air. I could put down these wings. Maybe that plane would never take off. Maybe that bus wouldn't fly the drop. Maybe that tumbleweed in me wouldn't leave every other sunrise. Maybe I'd settle down digging some roots. Find me a farmhouse, find me you. Maybe I wouldn't be already gone again if it weren't for the wind blowing, carrying me to the wire. White line rolling in the tire, smoking. I wouldn't be the rear view I'm looking if it weren't for the wind. If it weren't for the wind. Maybe that plane wouldn't never take off. Maybe that dust wouldn't fly the drop. Maybe that tumbleweed in me wouldn't leave every other sunrise. Maybe I settle down digging some roots. Find me a farmhouse, find me you. Maybe I wouldn't be already gone again if it weren't for the wind. Period. White line rolling in the sky. I wouldn't if it weren't for the wind. If it weren't.
I know you're worried at night. I won't find my way. And I'm tired of lying to myself just to get through each day. My head says I should have never left. And then my feet will soon lead to my death. I'm starting to question if God's trying to teach me a lesson. I'm starting to wonder if my true colors change since I left you. I used to shine bright like gold. Oh, now I'm already gone. My colors are darker and cold. I think it's time that I went home. Staying a while, always feel dead and wrong. Well, I used to shout out like gold, but now I'm all in the gold.
Gave up a piece of my heart, then I turned to run. Oh, my head's in the clouds, but I don't feel close to the sun. And the light fades away from my face, and the tears fall like rain. So I turn my words all into faith. Hope it's me that they say. I'm starting to question if God's trying to teach me a lesson. Lord knows I'm starting to wonder if the true colors changed since I left you.
Nothing's too strong. Now I'm all in the gold. My colors ain't all turning gold. I think it's time that I went home. Staying a while, always feel dead and alone. Well, I used to shout out gold, now I'm all in the gold. Starting to question, God trying to teach me a lesson.
Lord knows I'm
Starting to wonder, the true colors change since I left you. My colors ain't all gold. I think it's time that I went over. Stay a while, we see dead. I think it's shout now I'm all in the gold.
Used to spend my nights out in the ballroom. Liquor was the only love I'd known. But you rescued me from reaching for the bottom and brought me back, being too far gone. You're as smooth as Tennessee whiskey. You're as sweet as strawberry wine. You're as warm as a glass of brandy. Honey, I stay strong on your love
all the time. I've looked for love in all the same old places. Found the bottom of the bottle's always dry. But when you poured out your heart, I didn't waste it. 'Cause there's nothing like your love to get me high. And yours, Tennessee whiskey. You're as sweet as strawberry wine. You're as warm as a glass of brandy. Honey, I stay strong on your love all the time. Tennessee whiskey. You're as sweet as strawberry wine. You're as warm as a glass of brandy. Honey, I'll stay strong on your love all the time. Oh, that's Tennessee whiskey. Tennessee whiskey. Tennessee whiskey. Oh, that's Tennessee whiskey. Tennessee whiskey. Tennessee whiskey. Been gone for a little too long. I've been waiting on the drummer to kick off a comeback song. I've been waiting, knowing like a dog on a chain. I feel this fire, been up a little while, and when check the white, sure enough it's live, and trying to stop it, but it's calling me. Some more cowboy who dug his grave. His boots put his pistol on his head. I'm never to go to the rain. No in the yeah. And what's mine? Like a long lost out west outlaw out of his mind.
Nothing time. I'm saddle like some more. Well, great. Don't hold his head up, I'm the return of the rain. Oh, this place to sit up, I'm the return of the rain. Yeah.
Tonight I ain't bringing no wine. Tonight I ain't bringing no roses. Talking would take too much time. I think I just better show you. Let's turn the lights down. Let's get right down to it. As soon as I walk in the door, I don't want to be out of line. Girl, I can't wait anymore. I want you in the worst way. My hands in needing your lips. Want the first taste of whiskey off your lips. So close all the blinds, lock all the doors, put away anything that'll break. Baby, I need you tonight. Let's see how much love we can make. I want you in the worst way. Baby, that don't mean that I don't love to go wine and dine you. That ain't on the menu tonight. 'Cause I think I need to remind you that your skin on my skin feels just like heaven to me. You look like an angel tonight. You might want to slip off those wings. I want you in the worst way. My hands are leaving your hips. Want the first taste of whiskey rising your lips. Don't close all the blinds, lock all the doors, put away, pray. Baby, I need you tonight. Let's see how much love we can make. I want you in the worst way. You in the worst way. My hands are needing your hips. Want the first taste. Took me whiskey right off of your lips. Don't close all the blinds, lock all the doors, put away anything that'll break. Baby, I need you tonight. Let's see how much love we can make. I want you in the worst way. I want you in the worst way.
It'll be fine by dusk, but I'm telling you, baby. These things eat at your bones and drive your young mind crazy. But when you place your head between my collar and jaw, I don't know much, but there's no weight at all. I'm damned if I do, and I'm damned if I don't. 'Cause if I say I miss you, I know that you won't. But I miss you in the morning when I see the sun. Something in the orange tells me we're not done. To you, I'm just a man. To me, you're all I am. Where the hell am I supposed to go? Poison myself again. Something in the orange tells me you're never coming. Need to hear you say you've been waiting all night. Orange dancing in your eyes from bulb light. Your voice only trembles when you try to speak. Take me back to us dancing this wood used to creep. To you, I'm just a man. To me, you're all I am. Where the hell am I supposed to go? Poison myself again. Something in the orange tells me you're never coming home. To you, I'm just a man. To me, you're all I am. Where the hell am I supposed to go? I poison myself again. Something in the orange tells me you're never coming home. If you leave today, I'll just stare at the way the orange touches all things around. Grass, trees, and dew, how I just hate you. Please turn those headlights around. Please turn those headlights around.
I ain't saying that I always sleep alone. I ain't saying that I ain't met no one else. Done a little bit of midnight moving on. And I ain't saying when I do that it don't help. Leave with someone that I know.
Good morning. and welcome to this session on uncovering hidden gems in recent hernia literature. I'm the pleasure to co-direct this session with Dr. Knut Bosch from the Hospital or University of North. And I want to tell you that in hernia surgery, sometimes inconspicuous, well-designed articles can be as impactful and as landmark publications. These 4 papers we are going to present today exemplify innovation hidden in plain sight. The first is a large-scale appraisal of intraperitoneal mesh and the consequence of intestinal obstruction in the long run. The second is a nuanced method of measuring and also discriminating types of diastasis. The third one is a provocative editorial on artificial intelligence in surgical decision making. And the last one is a pioneer machine learning method to predict surgical outcomes. These are the hidden gems we are unearthing today for you. I hope they are intriguing and they are practice altering. The first presentation is going to be by Dr. Andres Hansen. Dr. Hansen is a director of surgery in Clínica Iberoamérica in Barranquilla, Colombia. He is a robotic surgeon from a long time. He was working in Venezuela. He's an academic surgeon, well known in all Latin America, and a great researcher. So the first article is going to be IPON and Intestinal Obstruction by Delorme. Please put Dr. Hansen. He's going to be presenting online because he's sick and he couldn't make it here.
Good morning, everyone. I really regret not being able to join today for this presentation. I'm really delighted to present this paper. It's a French, just a minute, it's not running. I'll do this again. As I said, I'm delighted to present this paper. It's a very recent paper published in Hernia Journal last year regarding the possibility of getting small bowel obstruction with IPOM technique. The title of the paper was Does Intraperitoneal Mesh Increase the Risk of Bowel Obstruction? And it was a nationwide French analysis by Dr. Delorme and their team. They compared, they stated that incisional hernia repair with mesh is standard, but mesh position is still debated. IPOM or IPOM, as is known today, is technically simple and is very widely used, but there are some concerns regarding additions, small bowel obstruction, migration of the mesh into the bowel. But until now, there are no large-scale data. They asked some questions, and the first one was if IPOM increased the risk of bowel obstruction. They studied a very large population from 2013 to 2014 that who underwent a laparoscopic intraperitoneal onlay mesh repairs after prior laparotomies, and they compared those patients with matched controls who underwent laparotomies but no hernia repairs. So they had 2 groups. The intraperitoneal onlay mesh group, who had abdominal surgery in the previous 3 years, and from 2013 to 2014, they got ventral hernia repair with intraperitoneal meshes, and the control group, and in these groups, the patients had abdominal surgery in the previous 3 years, They were hospitalized, but they got no intraperitoneal meshes. And they followed both groups till 2019 for 5 years, as you can see. So they selected 1,220 IPOM cases, and they identified 815 eligible patients after exclusions. The controls matched 2-to-1 the patients in the IPOM group, and both groups were matched for age, sex, type of initial surgery, and body mass index. You can see here the flow chart of the study, and after exclusions, they could recruit 815 patients in the IPOM group and 1,630 patients in the control group. They used the National French Hospital Discharge Registry, which is a huge database, and they included all patients with the criteria I described before. They excluded patients with more than one prior laparotomy during the follow-up period, and they followed both groups through 2019. They registered any hospitalization for bowel obstruction within the 5 years of follow-up, and the secondary outcomes they studied was if that small bowel obstruction episodes required surgery. They used the finding grade survival model adjusted for age and for the BMI. And they showed that small bowel obstruction occur in 7.36% of the patients in the IPOM group versus 4.42% in the control group, which was significant, which has a ratio of 1.71. So the risk of a small bowel obstruction nearly double the IPOM group when it was compared to the control group. The secondary endpoint is that, as you know, not every patient with a small bowel obstruction requires surgery, but they could find that that surgery was required in 4.66% of patients with previous IPOM versus 0.98% in the control group, which was also significant. So this was the first nationwide matches analysis showing a statistically significant small bowel increase risk with intraperitoneal meshes. This confirms some previous reports of additions, mesh shrinkage, mesh inclusion in the bowel, migration, and some other issues. And it adds some weight, some arguments against defending IPOM as equally safe as other positions of the mesh during ventral hernia repairs. Which are the strengths of this study? This is a nationwide study with a huge database, which represents a very, very impressive sample. Its match control design is very, very important. Controls for sex, for type of laparotomy, and if they had previous obstructions. The statistical method is accurate, and they used clear-cutting definitions for bowel obstructions and for surgery. So the results are strong, and as you saw, the findings are significant. What about the limitations? It's retrospective. The coding can be confusing and sometimes and not very accurate. The mesh type and the technique were not registered, and only laparoscopic IPOM were considered, not in open technique with intraperitoneal meshes were registered. The control group is a problem because it recruited only patients with prior laparotomies, but without hernia repairs. So the control group, in the control group, no mesh was used at all. So it's difficult to state that the mesh position is really related with this. It only demonstrates that when you have an intraperitoneal mesh, you will be probably more prone to develop a small bowel obstruction. So it is a little confounding from surgical selection and for complexity. What would be the ideal control group? Obviously, the best comparator would be patients with meshes in other planes, other positions within the wall, like retromuscular or preperitoneal positions for the mesh. It really would directly test if the risk of bowel obstruction is due to the intraperitoneal location. The current study, the paper we are discussing, really compares IPOM versus laparotomy and not IPOM versus meshes in other locations within the wall. But the strength of the evidence is very high. It's a very large data set with robust statistics, and it has very high internal validity. It is consistent with prior reports and registers in animal models and with previous reported clinical data, and supports avoiding intraperitoneal only measures whenever it's possible, favoring extraperitoneal repairs, as CTEP or ripstopper or some other combinations, without leaving a mesh in contact with the visceral content of the abdomen. So in conclusion, IPOM is associated with higher bowel obstruction and higher reoperation risk. The evidence isn't strong enough to recommend against IPOM when other alternatives are available, and future studies should compare IPOM versus meshes versus groups or patients with meshes in other positions within the wall. The message is that the convenience or the easiness of performing intraperitoneal only meshes comes with long-term high rate complications or high complications rate. That the risk of a small bowel obstruction is almost 5 times the risk when the mesh is outside of the cavity, and that extraperitoneal or retromuscular mesh placement is better aligned with the modern safety data. So an easy case today would mean an obstruction in the future. So these are additional reasons to favor the retromuscular or extraperitoneal position rather than the intraperitoneal position for mesh placement during incisional and ventral hernia repairs. But this is my favorite phrase of the study. They concluded the paper stating, quoting the Harry Potter saga, and it says that, as stated by Albus Dumbledore in Harry Potter's films, dark times lie ahead of us, and there will be a time when we must choose between what is easy and what is right. Thank you very much.
Thank you, Andres. That was a wonderful presentation. We have 10 minutes for questions, please, because there are various different topics, so it's better if we make the question for after each, I would say. Well, I have a comment. Don't you think, Andres, that the fact that previous laparotomies, more than one, were excluded, and the time of follow-up is long, but it's not, it could be longer, we are underestimating the real rate of small bowel obstruction after IPOM?
Yeah, it's probably true, but the issue is that when you have more than one laparotomy in the follow-up period, you could be attributing a higher risk, and the risk probably is related to repeated procedures and the additions related to those repeated procedures. So I think that the findings are accurate, and the risk it's really increased when you have an intraperitoneal mesh.
Okay, that makes sense from the methodology of the study, but in real world, people have more than one laparotomy and are followed for more years. So probably the rate of a small bowel obstruction is larger.
Yeah. Well, the follow-up period in this paper is long, is 5 years, but as you know, small bowel obstructions can occur anytime, and we have seen patients with small bowel obstructions 15 to 20 years after an intraperitoneal only mesh repair. So the time is crucial for this, or for answering this question, because small bowel obstructions can occur very late in the follow-up period.
Thank you, Andres. One quick question for the audience. Who have heard about this article before? No one. You see, that's why it's a hidden gem. The next one, please.
Dr. Hansen, very nice presentation. So this study pools a lot of different meshes into the IPOM group. What's your view on the different coatings of the IPOM meshes? Industry produces new concepts and put it on the market. Do you have any view on which adhesion barrier is the best, or do you think it's a way forward to find newer barriers?
It's very hard to tell, but as you said, there are so many options that makes us think that there's no of them is perfect. We started using PTFE meshes in the 90s, and we moved to some other coatings as OCR and collagen and everything. And when you go back to reoperate some of those patients, you will find that despite any kind of covering, you will find some adhesions. Some are worse, some are not that bad, but you will find adhesions with all kinds of coatings.
Thank you, Andres, and get well soon. We need you, my friend.
Thank you so much. Thank you so much, and I really regret not being with you today.
Okay, we'll go to the next speaker, Dr. No from the American Hospital in Paris. He will present to us the diastasis recti revisited.
Okay, good morning, everybody. And thank you, George, for your invitation to present our recent article published in the Journal of Abdominal Wall Surgery, entitled Some Additional Data That May Be Useful for Diastasis Recti Assessment. This one to change?
Yes.
It's forward. Thank you. Sorry. So diastasis recti is characterized by a separation of both rectus muscle over 2 centimeters and a protrusion of a medial bulging. The European Hernia Society distinguished 3 types of diastasis. Type D1 from 2 to 3 centimeters, D2 from 3 to 5 centimeters, and D3 over 5 centimeters. This article explains how to measure the interrectus distance and the deformation linked to it. The IRD depend on whether the muscles are at rest or contracting. In this case, in supine position, the diastasis is 7 centimeters at rest, but only 4 centimeters at legs rise. On this scanner, we can see on the left side diastasis at 11 centimeters in supine position at rest, but only 8 centimeters on exertion. And we can see the medial bulging linked to the protrusion of the enlarged linea alba. On these slides, on the right side, we can see the postoperative CT scan after approximation of both rectus muscle without the need of a mesh. This graph shows how measurements by tape and CT scan correlate. On the upper diagram, we can see that the values measured clinically at rest are overestimated compared to the CT scan. And on the lower diagram, we can see that the measured of the values measured clinically are close to the CT scan. Therefore, they might be considered closer to the real anatomy. This table shows that the type of the diastasis, according to the European Hernia Society classification, would be different depending on whether measurements are taken at rest or at leg rise. Type D1 at rest, known, but 13 at leg rise. Type D2, 46 at rest versus 82 on legs rise, on exertion. And D3, 59 at rest and only 10 on exertion. This study shows that the IRD varies significantly with the measurement between rest and exertion. The second data is the type of deformation linked to diastasis. This patient presents a medial bulging at legs rise on a supine position, and in standing position, a global bulging. And she says, it is as if I were pregnant. But a global bump of the abdomen, the diagnosis of the global bump of the abdomen, is not always easy. In this patient, she presents in standing position a huge global bump of the abdomen. That is the same for these other patients, and they were told by surgeons, your abdominal wall is too weak, no correction possible. In fact, these are diastasis, and they were corrected in most of cases. Patients' request is not to correct their diastasis, but to correct their deformation. And in our theory, we can observe that there is a medial bulging alone in almost half of the cases. there is a global bulging alone in 70%, combined bulging in 1/3, and no bulging at all in 5%. Thanks to this additional data, we can observe in our theory that patients with diastasis on exertion over 5-6 centimeters were not operated in most of cases. Patients with an RRD over 15 centimeters at rest were operated with tension-free suture. And the medial bulging is correct by approximation of both rectus muscle, and global bulging is improved by suture. But the global bump of the abdomen depends not only on the diastasis, but also on the other musculoaponeurotic structures. Then we suggest that besides the medial bulging, the presence of a global bulging should be included in diastasis recti assessment. And the interrectus distance should be measured not only at rest, but also on exertion. Thank you for listening.
Excellent presentation, Dr. No. Please, if you have questions, there is a microphone in the aisle you can use. Fernando, please.
Nice presentation, Dr. No. I'm sorry if I was not paying attention, or maybe not, but do you measure the percentage of visceral fat in these patients, abdominal visceral fat? Because that is a factor which not too many papers take into consideration of when we are trying to correct this issue, because we can be doing excellent surgery as you are explaining the rationale, but if you have visceral fat, it can be losing your time. I would like to know your feeling on this. Do you measure visceral fat or not with bioimpedance, electrical currents going through the hands and then through the abdomen, and measurement of the fat in the viscera?
Sorry, if your question is how to measure the RID in fatty patients?
No, the question is, do you think that what you are advising, what was advised in this article, that there is a flaw because there is no measurement of the visceral fat? That's what I mean.
I think the question Fernando is trying to make is, can you distinguish between a global diastasis and obese patient?
Sorry, my English is very bad.
No.
And I do not understand very well. How to distinguished? First, if it is incisional hernia, you have a scar. But sometimes it's difficult because you may have a scar and it is a bulging because there is no protrusion of peritoneum. Sometimes it's difficult and you have to inform your patient that there is two possibilities. And you can tell them that I start with correction of diastasis, but if it is not, you put in place a mesh in the room. You make the operation for incisional hernia, but sometimes it's difficult.
Yeah, it's the management of expectations. Yes,
But as you see in these patients,
yes.
they did not have any scars, so
Mhm.
it's easier.
Fernando, and
Thank you.
also to complement Dr. Snow's answer, I reviewed the article and most of the patient has a normal BMI.
Thank you. This is fascinating. I love the concept that you present of measuring both with contraction and at rest of the abdominal wall. I couldn't help but notice in one of your slides that the rectus muscle sometimes in the diastasis tapers and is very thin and actually turns up with the diastasis. So a couple centimeters of the rectus muscle medially almost seem part of the diastasis. And then in some of your CT scans, the rectus muscle was bulky and healthy and normal looking without that tapering. And I'm wondering if you specifically looked at change in the shape of the rectus muscle with contraction and whether that varied with the level of diastasis and how large it was or had any association with your other findings. Thank you. Does that make sense? If you want to go back on the CT, on the scans, I'll show you what I mean.
Well, he's asking if the diastasis variation inside can be just changing the contour of the rectus. Is that the question?
Yeah, so here, that's a good one. So look at your preoperative at leg rest. The rectus muscle actually goes up and into what looks like it's about to be the diastasis. That looks like a rectus muscle that does not function very normally. If you go back a CT slide, go back instead of pre and post op, go back. This one on contraction, the rectus muscle is actually very healthy all the way to the level of the break in the division of the rectus muscles. So I just found that very interesting. I'm wondering if you looked at that at all in your pre and post outcomes. Thank you.
Yes, but
Nope.
in practice, I think that most of time, CT scan and ultrasound are not very useful.
Okay.
I think that physical examination is enough because you can see and feel the diastasis.
Yeah.
When we make the CT scan, it's only on 40 patients, just to have first for our study, and secondly, patients like to see that there is no more diastasis and they like photo.
Right.
But we think that most of time it's not very useful, except for our first 100 patients. We find two mucosal, ovarian cyst mucosal.
Okay.
Appendix
Yeah.
mucoid.
Yeah.
And one ovarian cyst. So we have to choose.
Great. Thank you.
We have to move on.
Yeah.
Thank you so much. Well, the message is clear. You have to choose a standardized method to really decide on what type of procedure you are going to do. So what is similar to the taping is CT scan with the leg, raising legs. Thank you very much, Dr. No.
Thank you.
Thank you.
Thank you, John.
Well, the third article is on artificial intelligence and surgical decision making, and is going to be presented by Fernando Ferreira, general surgeon at the Hospital CUF at Porto. Welcome, my friend.
Thank you. Good morning, everyone. Thank you. It's an honor to be here. And I was given this task to speak about artificial intelligence. And at the moment, here we go. With regards to disclosures, I have nothing to declare because basically I know absolutely nothing about artificial intelligence before I read this article. And now I can probably say that I have a vast experience of this article and a few supporting articles. So going forward upon this, it's an interesting article because it's an editorial, and it comes to a point where it examines something which most of us shy away from, and it is important to approach this with clarity. So I came up with this way of approaching the article because, in a sense, the article does not have strong data to support it, but what it does is it approaches the problem of AI integration with the electronic uh, health records. And using this, we can enhance the outcomes of our patients. So again, what's important is that we have to create a platform for future care in these patients, especially looking at the option, at the problem that we still have learning going on, which is called deep learning amongst this area. And we as surgeons have the obligation to create the correct questions so that the deep learning, the situation of our computerized systems can know exactly how to create the correct algorithms with treatment. So these patients, sorry, I'm having some problems here clicking this. Anyway, with regards to this, as I said, as surgeons, we have to be in the forefront and not the data scientists. So we have to be there to have the correct questions, because a lot of times there are gut intuitions. There are situations which we have are only possible to discover as surgeons based on our experience. And it's our obligation to understand this. And a lot of times in the beginning, when we're discussing with our patients, when it comes to informed consent, we should inform them that we are using based AI information. So with regards to these traditional situations, we all know that we've worked many times and we're facing stress hours, etc., and our biases towards patients, towards colleagues, etc. And this will influence our patients, and many times it may influence them negatively. So it's very important to have an independent, without feeling system as AI, which will hopefully help us in the future. Standardize all our data and create a common pathway so that we can make good decisions. So I'll look at this slide here, and just for you to get an idea, when I finished training, I went to another hospital, which was way spread out. I was called, I was always on call. I was really tired, as most of you. And just remember this, you get called once, twice, you're running back and forth. And I had to go across 2 hospital buildings to see a patient. Okay. And this is really bad what they were calling me for, because they said the patient was saying inappropriate words and was swearing. And he was very uneducated. And I said, okay, how's the patient? Okay, give him haloperidol. It sounds almost like a Monty Python sketch. After 2 hours, how's the patient? Give him, oh, he's good, doctor, but not too good. He's yelling again. He's insulting us. Haloperidol. 3rd time. And I'm busy. And then finally, it's like, what happened? Is the patient really good? No, just a little fever. Wait a minute. What's he doing now? He's masturbating. Okay, this is horrible. But you get this horrible picture in your head. Okay. And then I go immediately when they said fever, right? Because as surgeons, we have the gut instinct. It's the dopamine in our body which motivates us and makes us go. So what this means is, if you look here, it's kind of blocked right now. There it's going. So we have all the data, which would say, okay, patient has fever, just give him paracetamol, whatever. But we also have our cognitive limitations because we are tired. We are influenced negatively. We think that this patient is not to value. So what happened afterwards? The patient, when I reached the patient, in reality had necrotizing fasciitis, was disoriented, and he was not masturbating, of course. He was having severe pain, and that's why he was frictioning his genitals. So I know this is a pathetic, or may seem as a pathetic example, but it is a true example, which embodies what has just been said here. And the hours that were taken and the cognitive function that was lost in a true protocol, I hurt that patient because I assumed negatively what I was doing. But with the AI and a proper deep learning situation, hopefully that will be overcome in the future. So we need more enhanced accuracy. And this article speaks about that. And so we have to keep participating and involved with this actively to ask the right questions, to review what is being presented so that we can have an automated data extraction in these patients. And what's really amazing is that having real-time support where you can cross and have everything in sync, which would be hospital records, laboratory reports, and radiology, and all that in sync with your mobile phone, that will help you immediately identify a problem and not go on to what has happened. And this is very important with regards to bias reduction. And of course, we have lots of studies which will influence negatively AI. That's why we have to come into this based on biased action. So as humans, as I said, the pattern recognition is very important, and we have to see what is life-threatening. And of course, looking at this patient, I saw it was life-threatening. And a lot of times we are taken into the wrong word or in the wrong direction if we are influenced. Basically, as they say, the patient is a person who is depressive. Right away, you're taking into the wrong situation. Or the patient, you look at the patient and you talk to the family, and the family will say, again, that's your intuition, that's your gut feeling, and you say that, oh, that patient never complains. And you look at the patient and you have something which is not really expressively objective, such as those dark eyes and they're kind of dehydrated and they're complaining, and they usually never complain. So it's the emotional intelligence with the family and the patient. So that's where we can come into this, okay? And it's important. Of course, we have to have data, good data quality, which has to be solid so that we can, continue to grow forward, and so that the machine, the deep learning machine, can learn upon this and go forward. So we can have seamless integration in every single hospital with every single situation, be it smaller, be it larger, be it in Portugal, be it here in the United States. And that's what's important, the scalability, so it can be applicable to any area. And therefore, we can continue to train other colleagues properly in this area. So again, the benefits, we know it will help us treat patients well and also avoid doing harm to the patients, avoid following errors, and being able to avoid very early if the patient is going into sepsis or if that patient is at high risk, which a lot of times, if you look at some systems that we used to fill out and a lot of, Apache 2, whatever, in a pancreatitis, it's time consuming, et cetera. And with this system, we're talking about in sync, on the hour, at the moment, knowing what's going on with these patients. So it's very important. And then ethically and legal at the moment, we have to have the duty to inform the patients. Of course, with time, the deep learning system will grow and it will be better. And of course, it will be better for us to achieve good coordination with our patients, who will also have their patient-reported systems, which will be cross-linked with everything that's being presented here today. So we'll have, in the end, enhanced patient care. We'll have policies which can be developed in favor of these patients. And in the end, what we'll have is a total integration of AI into our surgical practice. And we as surgeons, despite being something that we were not formatted to do, we have to play a key role for the best of our patients. And we have to get involved into AI. It's also a good option for many of the older surgeons who have vast experience and have that good gut feeling to know how to identify things, to also be involved. And slowly, we'll do careful implementation of everything. So here's a nice sunset. It's early morning, and thank you very much, everyone. And I'd like to wish you all nice trips back home. And of course, I'm trying to click here to finish off. Don't forget Porto next year, June 26th, the second, okay? And we're going to have the EHS meeting there from 3 to 5. It's a great time to visit, and bring your families if you like. And thank you again.
That was an amazing summary. If you have a question, please use the microphone at the aisle.
Hi, Eva from Portugal. I have a question, Fernando. From what you read in this paper, I'm all about AI helping us in the future. I think it can be great for all the reasons you pointed out. At the same time, I've seen the progression during my career that we used to think a lot, and now I see the younger ones, the patient comes in just asking blood workouts, CT, wherever, without critical thinking sometimes. Cannot be AI another reason for not having critical thinking about our patients? And I think we should really take care of that, not to be like robots. The AI tell us we do it.
Well, that's exactly it. And at the moment, if we follow AI precisely as it is, and it's still doing its learning, it's still going forward with the platforms available, you will have a lot of biased situations. I mean, you look at, for example, if you look at reviews of open abdomens, and you look at AI, will of course look at registries from the 80s. And we knew everyone in the 80s that open abdomens would reach up to 40 to 50% of severe trauma and septic cases. And now we've brought that down, at least in Europe, to close to 9-10%. So again, that's what we need. We need to be critical, and we need to intervene with our data scientists to make sure that we can basically fine-tune this situation. But as you said, it's inertia. It's as humans, we have inertia. And that's one of the big risks, of course.
So I think you answered my question, but I want to reframe it. If you look at the development of AI started at the end of the 60s at Berkeley, based on the Dreyfus model of skills acquisition, which was basically how do you take a novice and make them an expert, right? Yeah. And so we use those terminologies when we're assessing residents for competency. So there's this beautiful arc, right? It started in the 60s. It started with how do we develop expertise, and they layered it. It's the same technique they use for training pilots. How do we accelerate the novice becoming an expert, where they move to intuition? And so you mentioned this. So what is an expert, right? An expert is someone who breaks out of the rules, has intuition, and then the master can deconstruct or rationalize in a good way their expertise and then convert it into a language that the novice, the advanced beginner, the competent, the proficient can understand, which is what we're doing here, right? We have these experts on the stage, and we have novices. We have multiple people, multiple stages of delivery, and we're trying to bring that information. Okay, so this is what's important. Right now is a unique time. We are training the large language models. Intuitive is watching us operate. Everything we are doing right now, the LLMs are watching, and they're taking our expertise and they're training the model. And so this is going to happen at an exponential rate.
Yes.
And there's going to be a point at which the inflection point or the tipping point will be passed. And the programming of our collective expertise is going to be in the LLM. And it's going to be very hard for someone new who's developing expertise to actually impact. So just like there was a time when all the textbooks were being written, people started reading them, and then they stopped reading them. And we all said, well, why read a textbook? Because the minute it's done, it's old. And then we said, well, journals, right? Journals, let's just read journals. And now we don't trust journals anymore. And now we have a new place of learning. Let's say, you know, my partner Balasiri is putting all his videos. Well, guess what the LLM is doing? It's watching all our videos on YouTube, right? YouTube, owned by Google, is watching all of our videos. And so we are constantly programming the LLM. So that means that everybody in the room right now is in a unique moment of history. And in 100 years or 200 years, go as far out as you want, the model will be programmed. And so now the question is, if we recognize that right now is a unique moment in time, and people are going to look back at us as the people who created the expertise, so that everybody who's going through elementary school, junior high, high school, college is now just, you use AI, use AI to get the expert's opinion. It's going to tell me what expertise is. It's going to tell me how to critically think. That's the actual future. So what is our ethical consideration? What should we be doing now as the experts? Because in 10 years, the experts will have already trained AI and it's going to be done learning.
Thank you. Just 1 second. I think you touched upon something which is very important. We as surgeons have to be part of the regulatory body. That is the key, because you just said something that's so important. You see the videos with your partner Balasir. We know those are good videos, but everyone knows there have been videos out there which have unfortunately trained thousands of surgeons to do the wrong thing. So that's what we need. This is what the article touches upon. We have to embrace this, but we have to embrace it also as responsible surgeons who will act actively, okay, in the regulatory bodies. That's the key.
One more final question. Which surgical decisions should never be handed to the artificial intelligence, no matter how accurate it gets?
I think the problem at the moment with surgical decisions in pure AI, it's those that have the highest variables. So of course, it's those situations where you have an emergency procedure where you have so many variables that it is very difficult to go forward.
So emergencies, basically.
Yes.
Thank you so much. Would you present it?
Can we do a short poll in the audience? How many of you are using AI in your decision making today? Raise your hand.
Okay.
No? 5, 6. So still.
But in daily life, honestly,
Yeah, and in daily life, for ordering tickets, flight tickets. Yeah, it's a lot. So I comment on this article. It's already 5 years old.
Yeah.
And the speed of AI development is just tremendous. And I think there is a trend now that we're also moving again to smaller language models. So instead of using these huge LLMs trained on the whole internet, businesses are incorporating smaller models that is super trained on their data to produce better answers for smaller areas. So we might see small language models trained on our hospital data that gives us advice. Yes?
I just wanted to say something. That was a good presentation. I think this is obviously a very relevant talk. My name is Iselena. I'm a surgeon up in Illinois. But I think there's kind of two aspects to how we use AI in medical decision-making and surgical decision-making. And, when we talk about LLMs and the incorporation and, decision-making, particularly with hernia management, complexity of hernia repairs, component separation, things like that, that's all been studied. But I think for the lay surgeon who is not in the depths of research and using these kind of LLM models to decipher data and help interpret and analyze our research, I think the use of AI for the average surgeon is going to be in those standard decision pathways. And I think something that would be within something important for the experts to focus on educating our co-surgeons in is how to properly use AI in the sense of what are the limitations to it and how can it be misleading. And I think there's a lot being uncovered with that right now, especially with the use of chatbots and chat GPT and how, there are limitations to that because the AI, these systems will hallucinate. They will feedback if they have a history of your chats, they will feedback and guide you. And the goal of the chat and the goal of the AI decision making is to reinforce and to reinsure. And sometimes it can be very misleading and not necessarily data based. And I think we need to have a better understanding of that. And we see that a lot right now. There are stories about schizophrenics with their chatbots and how it will reinforce their delusions and their thoughts because that was the original purpose of these models. And so I think we need to be very careful with that because the use of ChatGPT right now, I would say if you talk to most residents and young physicians, they're using it for some medical guidance and decision making because it can quickly pull literature and data together. But I think you need to be really cautious about that because you don't always know where it's misleading you to.
Yep, exactly. I have my director of ICU who recently did a presentation also on this topic, and he just played around with ChatGPT, and he decided to say, I'm going to ask the pharmacy to justify the use of a chemotherapeutic agent for one of my ICU patients, and I'm going to transfer to another hospital, and to help them go against hypertension. Okay, the ChatGPT gave a perfect explanation written out for him to ask the pharmacy to transfer the patient with that chemotherapeutic agent justified. So that's how, it's just what you said. It's how dangerous we can feed wrong information to AI and use it. So we have to be careful. And again, regulatory body, that's our job. And it will be a job not only for more experienced surgeons, even other surgeons who are heading toward the end of their career, it could be a really great benefit for them. So a job opportunity. Thank you.
To reinforce the idea on the care you have to be with the artificial intelligence, we are in a pharaonic program right now. It's called the American Hernia Society Self-Assessment Program. I asked the experts to send me questions on their expertise in all areas of hernia. I am so frustrated to find that some misuse the artificial intelligence. You can find questions, for example, with the Carbonell index that relates defect to rictus width when is on the contrary. The numbers don't make sense if you invert that, but more of that, 50% of the references are hallucinated. They are perfect, but they don't exist. So be careful because now experts are using freely artificial intelligence and making very common mistakes. That should be taken into account in the use of it. You have to do the most of the work and simply for maybe redacting or correcting, the AI is still here, but not anything else, I would say. So,
thank you.
Thank you, Fernando.
Thank you very much.
So for the final talk, we'll stay in the new era with the machine learning. Catherine Cordero from Costa Rica will present an article on that.
Hello. Thank you very much for the society for the opportunity and Dr. Dias for all the preparation for this session. So for this session, we're going to be talking about this article. I have no disclosures or conflict of interest for this talk. And this is the article that was published in the American Journal of College of Surgery in 2022. So basically for the background, we have to talk about that previous studies reported hernia recurrence up to 42%, and overall complications up to 44%. After abdominal wall reconstruction, 30-day readmission and reoperation rates reported as high as 13 and 17%, respectively. Preoperative optimization and careful patient selection can lower complication rates, and that's why we pre-optimize our patients preoperatively. Identifying risk factors and the patterns and the interaction between these risk factors and the complications could benefit the individualized patient treatment. For what we have currently to measure this risk, most of us do the ventral hernia working group, the ventral hernia risk score, or the NSQIP from the American College of Surgeons. All these tools just have a linear correlation of risk factors and complication, unlike machine learning models that can identify non-linear relationships. So the machine learning is a branch of the AI, is a subfield that focuses on creating intelligent machines that can learn relationship and interactions in not a linear way of complex variables. So for the methods of this article, it was a retrospective core review of ventral hernia repair in a single center in the MD Anderson in Texas from March 2005 to June 2019. All surgeons were board certified plastic surgeons and reconstructive surgeons. For separation of components, they basically refer to an anterior component separation. They don't take into account for posterior separation. The tobacco use is referred as the use within 8 weeks of the abdominal wall repair. Obesity is a BMI of above 30, and the data set randomly was divided into training and testing. There was a Bayesian optimization used to select the hyperparameters for each algorithm to correct the class imbalance. It was an oversample strategy, and findings were reported with tripod. Then a decision curve analysis was used to determine the net benefit of correctly predicting complications, the true positives, versus the relative harm of incorrectly labeling patient complications, the false positives. So basically, they developed 9 supervised machine learning algorithms. These are the 9 of them. And for model validation and interpretation, permutation feature important analysis and accumulated local effect analysis was performed. The area under the curve, known as C statistic, was used for optimal model selection. Basically, it summarizes the overall accuracy of each model. 0 being completely inaccurate and closer to 1 being perfectly accurate. Sorry. So these are the models. And then for the statistical analysis that they used a stepwise model, and to-tail values of P of 0.05 was considered significant. The analysis were performed into the regular software that is used for results. There were 725 patients identified, 52% were women. The training set included 580 patients, which was 80% of the data. And the test and the validation data set was 20%. The age mean was 60 years old. The mean BMI was 31. The hernia recurrence rate was 12.8%. The SSO rate was 30%, and the 30 readmission rate was 10.9%. The mean follow-up was 42 months. So the machine learning model's performance for hernia recurrence, the best was the GLM with a high occurrency and an area under the curve of 0.71, closer to 1. For the SSO, the one that performed the best was the SVM with an area under the curve of 0.75. And for 30-day readmission, the one that performed the best was the MARS with a high occurrency and an area under the curve of 0.74. So for the model performance, the mean accuracy of the models was 85% for hernia recurrence, and we have the area under the curve of 0.71, and SSO 72%, and 84% accuracy for 30-day readmission. If we compare that to the multivariate logistic regression models that we currently statistically have, you see that the area under the curve was below, and the machine learning models were superior in each one of them. So in this, we can see the decision curve analysis, and if you take the net benefit with the threshold, it doesn't matter the threshold that you take into account, regardless of the threshold that you take into account, the net benefit of the machine learning models was greater than that of the reference model in each threshold that you could choose. And that's the clinical usefulness. So basically, with each one of these models, with the analysis for SSO, we could find that there were 12 factors that had the biggest weight or impact on SSO. And you can see that on the X value, the one that have a larger value, those are the ones that have higher impact. For SSO, we have obesity, BMI, and wound classification, and the rest of them. For hernia recurrence, the generalized linear model that performed the best, identify obesity, competent separation, bridge repair, and rectus muscle violation as the high risk factors. And for 30-day readmission, violation of the GI or GU tract, abdominal wall indication, and prior abdominal surgery were the factors that contributed the most for the 30-day readmission. So for the highlights, why this is a pearl is the first study to develop a machine learning model to predict outcomes for abdominal wall repair or reconstruction using available preoperative clinical data from the EMR. Using a prospectively maintained database of 14-year plus cumulative experience at a major tertiary cancer center, and operative cases were performed by 68 different surgeons, which gives some broader approach. For conclusions, we can conclude that machine learning algorithms trained on preoperative clinical data would predict more accurately the occurrence of hernia recurrence, surgical site occurrence, and 30-day readmission after complex abdominal wall reconstruction, outperforming every multivariate logistic regression models that we currently have. The machine learning model's prediction would more accurately identify who developed complications, the true positives, while taking the false positive into consideration also. Incorporating machine learning algorithms into the medical record would aid the individualized consulate and preoperative decision-making. It's not just a hernia, so we have to individualize the risk for each patient. The machine learning models can identify nonlinear patterns of complex variables as opposed to the risk assessment methods that we currently have. And the machine learning models can improve with more data, which this is paramount, because it has an incremental learning process and enhance the individualized risk prediction. This is so important. If we have more data, then these algorithms are going to be more reliable. Limitations. This is important to take it with a grain of salt because machine learning models, they lack interpretability and a decision must be made with the data. So it's not that you can rely 100% on them. The machine learning models showed high accuracy and specificity, but relatively low sensitivity that is explained on this data set by the low event rate. And it was a small sample. There need to be more data available, taking into account the patient-reported outcomes and the quality of life. It was done in a single cancer institution, so the patient characteristics are very specific to this particular group. Also talk about the competent separation that only took into account anterior competent separation and not the posterior release that is a gold standard, and the robotar that is widely popular nowadays. The retrospective design also is a limitation. There's need for a future perspective multi-center studies to build stronger models and improve the accuracy and prediction value. So the take-home message is that we can definitely achieve better outcomes with these models and with preoperative data available. If we include CT scan measurements, we can definitely individualize the risk and identification for risk and complication in abdominal wall reconstruction and attention to details and individualized risk assessment. And I want to invite you all to SAGES next year in Florida. Hope you can join us. Thank you.
We have a question from the floor.
Thank you.
Sure, thank you. I want to congratulate you because I love to see machine learning and Bayesian techniques now starting to get applied to surgical diseases and hernia. So that's fabulous. I wanted to ask a question about the purpose of the research because I wasn't clear about the findings based on what you did in the article. So seemed to me what you were doing in the article was you were showing that machine learning algorithms can achieve higher accuracy on internal data.
Exactly.
Is that right? So really this was a paper that was just showing that new statistical techniques exist.
Yeah.
And are available, right? Because it wasn't an article that you were trying to show any particular findings between preoperative risk and postoperative.
Yeah, I think
Right?
it's important that it's preoperative data that you have,
Mhm.
like in your electronic record, and they were trying to show that it had high accuracy and reliability, but with the limitations that we discussed. It's a publication from 2022. So
Right.
there was actually a publication from 2024 from Professor Henneford and Diego Lima, and it was the first systematic review related to hernia. I would recommend it. It's great systematic review, and it would give you a better perspective of where we are. Machine learning algorithms and models are still a promising tool that we need to take still with caution because there's we need stronger databases so we can really apply this to like bigger populations, right?
Yeah, I guess the reason I was asking was because it seems to me, one of the things we can do in statistics is we can build bigger and better models to achieve higher accuracy internally. But what the gold standard is and what we're trying to achieve is higher accuracy in the future. And one of the ways that most statisticians would use machine learning models is they use a sample and then they use another part of that same data set to predict that sample. And probably one of the biggest problems that we have in surgery is that technique changes over time. For instance, that was MD Anderson 2005. First of all, all of them are open. Second of all, almost all of them are onlays. Third of all, almost all of them are biologics. And then, right, so these are like, we see very little open onlay biologic repairs now because of a lot of the findings from that data. And so what I'm curious about is that whether you've expanded this work, not just to say machine learning models can be used to better, more accurately predict internally, but that they actually can be helpful in prediction of, sample set and future set and how that work maybe is going right now.
Yep.
So
Just
thank you.
like the other doctor commented, if you have a bigger database and more variables into account, you're going to have more reliability and broader application of the models, right? So
Yeah, I mean, that's
so
the
we're
basic
getting-
statistical principle. I just was curious whether you did that on your date, right? So you have a large data set for MD Anderson, right? I was just wondering if you also applied that same question to a predictive model plus within that data, right? You have 10,000 data points, you take 6,000 of them, and then you're trying to predict the next 2,000. And then you take that 8,000, and you're trying to predict the next 2,000. That's a different question. And so I was just wondering if you used it to do something like that.
So if I interpret your comment well, bias is not just natural to the natural intelligence, but also to the artificial intelligence. That's bias.
Right.
Because
What I'm saying is that overfitting of a model is very well established statistical principle. And one of the things we worry about with machine learning is overfitting, which means that you do an excellent job internally. And then as soon as you take that data and you go to Spain from, Houston, Texas,
it's not going to
it
apply.
has no predict, right? And then one answer is to say, oh, the data needs to be bigger. But the other answer is to say, actually, there are ways within a given data set to predict what pieces of that data set are going to vary, and therefore higher accuracy is not necessarily better.
Exactly.
That's all.
Definitely.
Yeah.
100%.
thank you. Any more questions? Even question from the past presentations, you can be invited to do it. Any comment? Okay, thank you so much for being here on Saturday. Hope to see you again next year. Bye-bye. No.